Okay, good afternoon. So today we are going to continue with the skeletal system. Last time we started the skeletal system and we studied the histology of the skeletal system, including the histology of cartilage and bone. And today I'm going to deal with the gross anatomy of the skeletal system. So I will start with the axial skeleton because there is an axial skeleton and appendicular skeleton. Now this slide here does not only show the objectives like any other lecture, because you find here that there is a link to a virtual anatomy lab video. So I suggest that you watch after the lecture and take some notes. If there's anything that is not mentioned in the lecture, then you can add these notes to the lecture. And also it tells you that there's a self-assessment PowerPoint file which you can find in the course content and download, and it is linked to this lecture. Again, this is not a task that is due, that you are required to submit, as many of you have asked before. So this is you can download it and you can view it as a slideshow view. This is where to get to slideshow view. You can see the icon here. I'm saying that because I have received emails asking me, so that's why I'm saying that. Sorry, I mean, I don't mean that you don't know, but some people don't know that. So this is how to go to the slideshow view, okay? And then here you can see that, for example, these are the types of questions that probably you will have in the lab test. So you can see here in slideshow view, you will not see the answer. So you think about the answer. It's all identification. So if you are using a computer, you can click. If you are using an iPad, you can tap. So once you tap, you will find the answer and so on. So all of them, if you don't view them in the slideshow view, then you will have all the labels in front of you. So you cannot use it for self-assessment. And after you finish, that's it. You don't need to submit it. It is not a task that needs to be submitted. Also, you will find here a note saying that you are not expected to learn all the bones or their surface markings. However, because this chapter is very big in the textbook. So however, you are expected to know about the location and function of the bones indicated in the presentation, and I may add to that, and Dr. Gary Allen's videos as well, which are probably almost the same. So as I said, today I'm going to deal with the gross anatomy of the skeleton, and it's an axial skeleton. The axial skeleton, which as its name indicates, lies along the longitudinal axis of the body. It has several bones. We are going to study them separately. Bones of the skull, the hyoid bone, this bone which is U-shaped and is present in the neck, then the vertebrae, and then the bones and cartilages of the thoracic cage, ribs, costal cartilages, and the sternum. So these are the bones that are colored in blue. And the other part of the skeleton, which is called the appendicular skeleton, we are going to study it next week. It is the bones of the upper limb and lower limbs and the girdles that are related to them. So there is here, we have a pectoral girdle having a scapula and a clavicle. This is a girdle, and then the bones of the upper limb. And here we have the pelvic girdle, which consists of which is formed of the hip bone, that are three bones fused together, and then the bones of the lower limb. Also here, I want to show you the ossicles, the small bones that we are going to study in more detail. Three bones, malleus, incus, and stapes, that are present in the middle ear cavity. You can see the size of these bones and compare it to the fingers and the tip of the finger, smaller than that. And they are present in the bones of the skull, within the bones of the skull, and they are considered a part of the axial skeleton. So the skull in general has several bones. They are connected with each other by different types of joints. Mainly they are fibrous joints called sutures. And these bones can be divided into cranial bones that form the cranium, which is the brain case, the case of bone that contains the brain, and the facial bones. They form the face. They contain the main sensory organs like the eye, olfactory sense organs, the tongue for taste. Also, they contain the beginning of the respiratory and digestive passages. They are called facial bones. So the cranial bones are attached, some muscles of the face. These muscles are also called muscles of facial expression. We're going to study them later on because they are, from one side, they are attached to bone, and from the other side, they are attached to the skin. So they can wrinkle the skin. They can move the skin and produce the facial expressions. Usually, muscles are attached between bones and they move bones, but these muscles are attached on one side to bone. On the other side, they are attached to the skin, so that's why they can move the skin. Some other muscles move the mandible, and so they are called muscles of mastication because they are used for chewing. And, of course, there are other muscles that would be connected to the neck, muscles of the neck. These are the cranial bones. Usually, they are flat bones. Remember, flat bones that ossify by intramembranous ossification. They have a double layer of compact bone, and in between them there is a sandwich of cancellous or spongy bone. We have obviously one frontal bone here. You can see it from here, from there. And there are two parietal bones. And then there is a temporal bone, a sphenoid bone. We are going to see the sphenoid in different views because it's a very complicated bone and tricky, can be seen from several places. This in this area, it has wings, two pairs of wings, called greater wing and lesser wing. So this is a big wing, a greater wing of the sphenoid to be specific. It's part of the sphenoid. And then there's another one, another tricky bone here on the medial side of your orbit. It's called the ethmoid bone. And of course, the occipital bone on the back, the occipital bone. Now, if you look at it here, this is the frontal bone again. Look at the frontal bone. This is a mid-sagittal section of the skull. You can see the cavity, the big cavity. This is the cranial cavity. And it has three fossae, depressions, like staircase. So there's an anterior cranial fossa, middle, and posterior cranial fossa. So you can see the frontal bone, in addition to being in the forehead, it forms the roof of the orbit, and at the same time, it forms the floor of the anterior cranial fossa, floor of the anterior cranial fossa. There's something else about this bone, is that it has a space here, cavity. It's called the frontal sinus. This cavity is unlike the medullary cavity that you have seen in the long bones that contains the bone marrow. This one does not contain bone marrow. It contains air, and it is lined with respiratory epithelium. Remember the respiratory epithelium, the pseudostratified columnar ciliated epithelium, and it is connected to the nose. So it's an air sinus connected to the nose, and it is one of the what we call paranasal, because there are many surrounding the nose, so they are paranasal sinuses. If this sinus gets inflamed, specifically, you will get pain in the forehead because it is located inside the bone. Then we have the two parietal bones. This is the parietal bone on the side and the temporal bone. The temporal bone has many pieces. One of the pieces usually is on the lateral side, and one of the pieces, it has a process here which fuses with the cheekbone. The cheekbone, which you can feel here, is the zygomatic bone. It's a bone of the face, but it fuses with the zygomatic process of the temporal bone. And it has a flat part, squamous part, and has another process here, which you can feel behind the auricle, which is called the mastoid process. You can see here that in front of it is the opening of the ear, the external auditory meatus. So that's the external auditory meatus. Behind, you can feel the mastoid process, and just in front of the auricle, if you put your little finger here, open your mandible, it dips, because in front of that there is a fossa. Where is it? Yeah. So this is a fossa here. You can see it from below. This is a view of the skull from below. It's called the mandibular fossa because it is here that the mandible articulates with the skull. So this joint is specifically called temporomandibular joint because the mandible articulates with the temporal bone of the skull at the mandibular fossa of the temporal bone. So it's called temporomandibular joint. The word temporal. What's the meaning, literal meaning of the word temporal? It is meaning something related to time. The origin of the term temporal, because this region of the head is the temporal region of the head, because here the effect of time appears at the beginning when the hairs become gray. So the first gray hairs, they will appear in this region. So this region is the region that reflects time, so it's called the temporal region, and the bone underneath is called the temporal bone, and the lobe of the brain, which is deeper, is called the temporal lobe of the brain. That's how it started. The occipital bone is a single bone located posteriorly, occipital bone. And if you look at it from below, you can see that it has a big foramen. In fact, the occipital bone is not the only bone of the skull that has foramina. You can see that there are a lot of foramina here. You are not required to identify them or name them, but you can see, and you can expect that these foramina help in the passage of blood vessels and nerves between the skull and the cranial cavity and the outside. But this one is the big foramen. That's why it's called the foramen magnum. It's the big foramen, and it transmits, or it is the foramen where the brain, to be specific, the medulla oblongata of the brain, will be continuous with the spinal cord, because the spinal cord is present in the vertebral canal, which is located below from here down. And you can see here that on either side of foramen magnum, there is a process of bone, which is called occipital condyle. This is where the skull articulates with the first cervical vertebra, which is called the atlas vertebra. So the joint between the atlas and the occipital condyle should be called, between the atlas and occipital condyle, what do we call the joint? Name it. Atlanto-occipital joint. So it indicates the two articulating bones. And it is the joint that we use it when you say yes. Okay, so that's the joint, the atlanto-occipital joint. In other words, this is how the vertebral column articulates with the cranial cavity, and this is how the dorsal body cavity continues from the cranial cavity to the spinal cavity, which is present inside the vertebral column. Then we have this complicated bone, the sphenoid bone. If you look at it from here, this view, this is a view of the inside of the skull. We are looking at it from above. We removed the calvaria. We removed this piece, which is called the calvaria, has been removed. And I am looking at it this way. Okay? What are these? Yeah. So this is the base. This is the floor of the cranial cavity. So we have an anterior cranial fossa, middle cranial fossa, and a posterior cranial fossa. You can see that the green bone is the sphenoid bone. It has a body and wings, lesser wing, greater wing, lesser wing, greater wing. It is this greater wing, which I can look at it from the other side, from the outside of the skull, and it is here. So that's the greater wing of the sphenoid. When I look at it from the outside, okay? And here it is when I look at it from the inside. It looks like a butterfly. And here in the middle, there's a body of the sphenoid. And the body is a little bit excavated. It has a fossa or a depression. Looks like a saddle. So they call it sella turcica, means Turkish saddle, because it looks like a saddle. And it contains this part of the brain, which is called the pituitary gland. So that's why sometimes it's called the pituitary fossa or the hypophyseal fossa. This is called hypophysis cerebri. We're going to talk about it when we deal with the endocrine system. This is a main endocrine organ in the body. Now, if you break the bone here or look at it at this location, you will find that the body of the sphenoid is empty. There's a space, an air space. This is the sphenoid air sinus, the second air sinus. There are 4 pairs of air sinuses. I mentioned the frontal And now this is the sphenoid air sinus. So the sphenoid also has an air sinus, paranasal air sinus, that is, again, it is connected to the nose. You can see the close proximity of the sinus to the nose. This is the nose, nasal cavity. So that's why, for example, like when they sometimes when they treat tumors of the pituitary gland, how do you expect that they reach the pituitary gland? They're not going to open the skull and remove the brain and take the pituitary gland. And no, they access the pituitary gland from here, break the bone, and here we are. So they access it through the nose, and they can deal with the tumor of the pituitary gland. The other bone is the ethmoid bone. It again is the other complicated bone. I'm sorry for that. You can see part of it here in the floor of the anterior cranial fossa. The other part is located on the sides of the orbit, as I mentioned, and it is full with air. So it has air spaces, air sinuses. And this is the third pair of paranasal air sinuses, the ethmoid. That's why if you examine the skull in a dried skull, you will find that most of the dried skulls, especially the used ones, the old ones, with multiple use, I mean, the medial side of the orbit is broken because the bone is very thin as it has air inside it, so it becomes very thin, easily broken. Many students, they hold the skull from the orbits, and the bone breaks. It's better to hold the skull a dried skull from the foramen magnum, the foramen that is present in the occipital bone. This bone has a plate here, which is called cribriform plate. Cribriform plate, or the name ethmoid, all means that it has multiple perforations, sieve-like. And it is perforated, has multiple perforations, because there are a lot of nerves, about 20 pairs of them. They pass through the bone from the roof of the nose. These are olfactory nerves for the sense of smell. So they make all these perforations and make the bone sieve-like, and that's why it's called the cribriform plate of the ethmoid bone. Added to the complication of this bone is that if you look at the bone here, the separate bone, you will find that it has a perpendicular plate that goes down, because this is the roof of the nose where it is pierced by the olfactory nerves. So that is the roof of the nose. So you can expect that this plate of bone is present in the septum of the nose, the septum that is present in between the two nostrils. There is a bony septum. So in addition to cartilage, there is bony septum, and part of the bony septum of the nose, as you can see it here, is part of the ethmoid bone. The other part is the vomer. I'm going to show it to you in a moment. And again, part of the ethmoid is that it has some shelves on the lateral side, shelves of bone. These will be covered by mucous membrane here, called superior and middle concha, on the lateral side of the nose. And this is to increase the surface area of the mucous membrane of the nose. We're going to talk about this in more detail when we study the respiratory system. But we need more surface area here, because one of the functions of the nose, the nose is not only for olfaction, but the nose also, it humidifies the air, it warms the inspired air, and it filters the air. And for that reason, it requires a big surface area. Only a small part of the nose is for olfaction, and that is on the roof of the nose. So that's why when you want to smell something, that's how you smell. You take a breath like that in order to make currents of air going up into your nose, because the olfactory area is only restricted to the roof of the nose. Now the facial bones. We said that there are cranial bones and facial bones. Facial bones, we have these small tiny nasal bones, because the external nose is partly cartilaginous. Which type of cartilage here? Which type of cartilage in the nose? Is it fibrous, elastic, or hyaline? Hyaline cartilage, okay? And then we have the lacrimal bones, small tiny bones, and the zygomatic bone, the bone of the cheek. And then we have the palatine bone at the roof of the mouth. So now if you touch the roof of your mouth, not with your finger, with the tip of your tongue, you will feel that it's hard. If you go back it becomes soft. So there's a hard palate and a soft palate. The hard palate is partly formed by the palatine bone, as the name indicates. And the main part of the hard palate is, in fact, it is the maxilla. So this bone, the upper jaw bone, which also has the sockets for the teeth. And the other bone of the face is the mandible, which, as I said, articulates with the temporal bone at the temporomandibular joint. And there is another bone here, which is called the inferior nasal concha. Now, if you remember, a few minutes ago, that when I was saying about mentioning about the superior and middle concha, I omitted this. This is the inferior concha. Here it is. This is the inferior concha. I omitted it because this is a bone by itself. And this slide was dedicated for the ethmoid bone. And the superior and middle concha are part of the ethmoid bone. But when it comes to the inferior concha, the other shelf, the bigger shelf on the lateral side of the nose, it is a bone by itself, considered part of the facial bones. The other facial bone which we have here is the vomer. So this is the vomer. The word vomer means plow. So if you look at it from the lateral side here, it looks like the metal of the plow, this one, okay? And this constitutes part of the nasal septum. Here, these two bones, this one and this one, they constitute the bony part of the nasal septum, and the remaining part is cartilage. Okay, so that's how it looks, the nasal septum. So part of it is bone and part of it is cartilage in the nasal septum. Now the maxilla also has sinuses inside it, paranasal air sinuses, which makes up 4 pairs of paranasal air sinuses. The frontal has paranasal air sinuses, the ethmoid, the sphenoid, and the maxilla. In fact, the air sinus that is present in the maxilla is the most difficult to drain if it is inflamed. Usually these sinuses are inflamed as a complication of an upper respiratory tract infection, and there will be mucus because of the excessive mucus production. Maybe this mucus will change into pus because of the infection, and they will become blocked. And when they become blocked and when they become inflamed, they will affect the quality of your voice. If you have that before, sinusitis they call it, the quality of the voice is affected because one of the functions of these paranasal air sinuses is that they act as resonating chamber for the sounds, in addition to the fact that they reduce the weight of the skull, okay? And they might have other functions as well. But these are the 2 functions that, I mean, logically we can say that they are the functions. But the way that they are there, the complication, the way that they are connected to the nose, lining by respiratory epithelium, doesn't seem like they are just only resonating chamber for the voice or just to lighten the skull, okay? You can see here that the drainage of the maxillary air sinus is against the gravity. So that's why it is difficult to drain, and sometimes it might need like some sort of physiotherapy to drain it. You put the head in a certain situation so that it can be easily drained. Sometimes even surgical draining is required. Now between the bones of the skull, I hope that you remember this slide. This was exact same slide used in the first lecture. And you can see that between the bones of the skull there are places, joints which are called sutures. These are fibrous joints, immobile joints in the adult. But in the fetus and the newborn, they are the fibrous tissue in between them is wide, especially in these places, anteriorly and posteriorly, and they create what is called the fontanels. You can see this is an actual fetal a newborn skull. You can see the size of the anterior fontanelle, the space that is covered by fibrous tissue. And these fontanelles, they are to allow not only the fontanels, but the wide sutures, to allow for the bones of the skull to overlap each other during the passage of the head through the birth canal during delivery, because the head is the least compressible part of the fetus. So they allow these bones to overlap each other. In addition to that, they stay there until the first year of life, second year of life, especially the anterior fontanel. It stays up to 18 months of age, and they allow the rapid development of the brain. The brain develops so rapidly during the first year of life, so they allow accommodate this rapid development of the brain. Fontanel means a small fountain, and the reason for that is that in the Middle Ages they discovered that in some newborns who have an increased intracranial pressure because some sort of congenital anomaly, there is something that prevents the drainage of blood or drainage of the cerebrospinal fluid inside the brain. So there's a lot of pressure inside the skull, and the fontanels will bulge. So they put a knife, opened it, and the blood and the CSF gushed out like a small fountain. So they said, oh, let's call it fontanels. So that's why they are called fontanels, which mean a little fountain. So far about the bones of the skull. Now let's deal with the hyoid bone. Another bone. This is the bone that does not articulate with any other bone. So how is it kept in place? It is kept in place by muscles and ligaments. It does not articulate with any other bones. It acts as a base for the tongue, and it allows the attachment of muscles of the neck, muscles of the pharynx, and so it moves with swallowing as well. It is the bone that is broken if somebody dies because he was strangulated. Usually this bone breaks. It's a small tiny bone missing in many of the skeletons in the lab because it does not articulate. So they miss it. And it has a body and not two wings but two horns. So a lesser horn and a greater horn of the hyoid bone. The vertebral column, obviously, it supports the body and head. As I said, that the head, the occipital bone, articulates with the first cervical vertebra, which is called the atlas. It surrounds and protects the spinal cord because, as we said, that the brain continues with the spinal cord through foramen magnum, and provide attachment sites for the ribs and muscles. This is these are the pieces of the vertebral column, the vertebrae. We have 7, so as the giraffe has 7 vertebrae in the neck, 7 cervical. The first one is called the atlas, and that's why the joint is called atlanto-occipital joint. And we have 12 thoracic. We have 5 lumbar in the lumbar region, and then in the sacrum, it's a single bone. This is the sacrum here. It's a single bone, but in fact, it is 5 fused segments, vertebral segments, okay? But they fuse together to form single bone, but it is 5 fused segments. And then we have the coccyx. The coccyx is the tailbone. In animals, it's very long, but in humans, this is the remnant of the coccyx. It's very short, and it is formed of 4 tiny small segments fused together, the coccyx. Now, this is important to understand here. This is like a typical vertebra. You will find that in any vertebra, there is a body of the vertebra. Here we are looking at the vertebra from above. Here we are looking at the vertebra from the side. This is anterior and this is posterior. This is anterior and this is posterior. So this is the body of the vertebra. As you will see here, that the body is the part of the vertebra that withstands the weight. So the weight of the body comes through here and it transmits the weight to another vertebra. So as we go down in the vertebral column, the force will increase because the weight is increasing. So thoracic, for example, cervical vertebra, you don't expect that they have big bodies. But as we go down and reach the lumbar region, the bodies will become larger and larger until we reach the sacrum, and then the size will become smaller because the body weight is going to be transmitted to the lower limb. So the body is the weight-bearing part, and then after that we have the arch. So this is the vertebral arch. The arch and the body, they surround a foramen, which is called the vertebral foramen. And if we have vertebrae on top of each other, like we have it here, this results in the formation of a canal. Multiple foramina on top of each other will form the vertebral canal. Now this arch, attached to the arch are processes. We have two on the sides, like two upper limbs, like that, transversely, so they are transverse processes. And then we have one posterior, which in most of the vertebrae it is tapered, so it looks, that's why it's called spinous process. And you expect that these processes, they will receive the muscle attachments and cause the movements. But in addition to that, we have a superior and inferior process, actually double. So a pair of superior, a pair of inferior articular processes, because these processes provide another place where the adjacent vertebrae can articulate with each other. So they are articular processes, but they are not weight-bearing. They allow movement between the vertebrae. The weight-bearing is the body. And so when the bodies articulate between each other, they articulate with a fibrocartilage in between. Remember, the fibrocartilage is the strongest type of cartilage in the body. And the arch is formed of two pieces. This is one piece called the pedicle, which is the part of the arch between the body and transverse process. And then we have the lamina, which is more flat, lamina, laminated. So this is the flat part again. This is another lamina between the transverse and spinous process. So we have pedicle, lamina, lamina, pedicle equal the arch. The pedicle has a notch. If you look at the pedicle here, there is a small notch here, and there is a big notch on this side. If you bring two vertebrae together, these two notches, they face each other. You have a notch from the vertebra above and a notch from the vertebra below, and so you will have a foramen. And this foramen is between the vertebrae, so it's called intervertebral foramen. It is not a defect in the vertebra. It is not a hole in the vertebra, but it is because two vertebrae come together, they have notches, and so this creates a foramen. It's not a hole in one bone, but two notches in adjacent bones. It is the intervertebral foramen, and it is through the intervertebral foramen that the spinal nerves leaves the spinal cord and become distributed in the body, okay? Through the intervertebral foramen. We're going to talk about this when we deal with the nervous system. And here, this is the joint between the two vertebrae, between the two vertebral bodies, where there's a lot of weight bearing here. So the joint is a secondary cartilaginous joint. It is called intervertebral disc. And this disc consists mainly of fibrocartilage. In fact, it consists of a rim of fibrocartilage, an outer circular rim of fibrocartilage called annulus. Annulus means rounded, circle, and annulus fibrosus. And in the middle, there is again cartilage in the form of a gelatinous material or a mucoid material, and it is called the nucleus pulposus. So there is an annulus fibrosus and nucleus pulposus, and the presence of this will make it withstand a lot of pressure, and at the same time it acts as a shock absorber. That's why we have the nucleus pulposus. And so you can expect that if you are standing for a long period of time, then at the end of the day, this nucleus pulposus and annulus fibrosus will get compressed, becomes a little bit thinner. And there are a lot of these in between the vertebrae. So at the end of the day, if you are standing for a long period of time, you will become 1 centimeter shorter than when you wake up because of the compression in the intervertebral discs. So these intervertebral discs, they withstand a lot of pressure. It is how the body weight is transmitted through them. and they act as shock absorber, especially the ones that are present in the lower part of the vertebral column in the lumbar region, not on the sacral region. Sacral region, we don't have them because the sacral segments are fused together and the body is going to be distributed to the lower limbs. So we are talking about the last two lumbar vertebrae, the intervertebral disc between L4 and L5, and the intervertebral disc between L5 and S1. Usually these are subjected to a lot of pressure and they might slip, as a common term is used, but the scientific term is that they herniate. What happens is that the inside, the gelatinous material which is present inside the donut here, it herniates through the annulus fibrosus, and as it herniates posteriorly, it's going to compress the structures that are present in the vertebral canal. And these are nerves. Usually they are nerves, and their surrounding membranes. So this results in nerve damage, resulting in what we call sciatica. Again, we're going to talk about this when we deal with the nervous system. So the patient will have paralysis, will have pain, paresthesia, tingling, because of that. And in order to relieve the tension, to relieve the pressure here, they usually make an incision at the back and they remove the laminae with the spinous process of that vertebra. And that's why the operation is called laminectomy, cutting of the lamina. Remember the laminae, which are the part of the vertebral arch, the flattened part of the vertebral arch. The vertebral column has curvatures. So in the fetus, it has a single curvature, as you can see it here, as it's called the primary curvature. But then later, a second curvature, two secondary curvatures will form, one in the cervical region, and this is the first one to form in afterlife. It's when the baby tries to hold his head, because at the first 3 months of life, the baby cannot hold his head. But when the baby holds his head, this curvature, which is convex forward, not concave, convex, is called the cervical curvature appear. And then after that, when the baby starts to sit and especially to walk, there will be another curvature, a lumbar curvature. This is another secondary curvature, which is convex forward. There are abnormal curvatures, like scoliosis, which is a lateral curvature, and kyphosis, which is accentuation of the thoracic part of the of the vertebral column, and lordosis, which is an accentuated curvature of the lumbar region. For the thoracic cage, it protects thoracic and upper abdominal organs, provides support of upper limbs, and plays a role in breathing, because when the ribs move, as we will see that in the respiratory system, they change the dimensions of the thorax and will make a negative pressure inside the thorax, which sucks the air in. But here I want to say something about protection. They protect like lungs and heart in the thorax, but they also protect upper abdominal organs. The reason for that is that the diaphragm, which is used for respiration, it's a thin muscle, but it is dome-shaped. It's like that. So as you can see that if you have an upper abdominal structure here, like the liver, it will be enclosed by the lower ribs. Same thing is true about the spleen on the left side. They are in the abdomen, but they are enclosed by the ribs, because part of the abdomen is located or is surrounded by the rib cage. It's not in the thoracic cavity. The thoracic cavity is here. It is above the diaphragm. This is the thoracic cavity, but this is the abdominal cavity enclosed by the upper ribs. You can see here, for example, this poor guy in autopsy, he has a fracture of the lower ribs that injured the liver and probably injured his spleen, and these usually they result in very severe internal bleeding that results in death if not treated immediately. Now, the thoracic cage consists of ribs, costal cartilages, these dark brown structures, and the sternum. And as you can see that all the ribs anteriorly, they articulate with a costal cartilage. Even these ribs, they articulate with costal cartilage. There are 12 pairs of ribs, and the upper 7 ribs, their costal cartilages, they directly attached to the sternum. So these upper 7 ribs are called true ribs. Not the rib itself, but its costal cartilage. Rib 8, 9, and 10, the costal cartilage of 8 attaches to that of 7. Of 9 attaches to that of 8. Of 10 attaches to 9. So in other words, they are indirectly connected to the sternum. They're costal cartilages. That's why they are called false ribs. The last 2 ribs, their costal cartilages do not articulate with the sternum at all, neither directly nor indirectly. So they are just floating there in between the muscles. That's why they are called floating ribs. The rib has a posterior end, which has a head. And as you can see that the head has smooth areas here, facets for articulation. In fact, the head of the rib articulates with the body of a vertebra. Usually it's a thoracic vertebra because we don't have ribs. Normally we don't have, or usually we don't have ribs in the lumbar region. We don't have ribs in the cervical region unless we have a variation, a cervical rib. But the ribs are usually they are restricted to the thoracic vertebrae, or they articulate with thoracic vertebrae. And then after that, the head, there's a neck, and there's a tubercle. Again, the tubercle has a smooth facet, but this facet, if you fit it with the vertebra, it articulates with the transverse process of the vertebra. So the posterior end of the rib, because the anterior end is attached to a costal cartilage, the posterior end of the rib articulates with vertebrae, the head with the body of the vertebra, and the tubercle articulates with the transverse process of the same vertebra. The sternum is the bone that is present in the midline. It is one of the flat bones, like the ribs, remember, and it's just underneath the skin. It looks like a dagger, and that's why this pointed part of it is called the xiphoid process, which means the tip of the dagger. This is the body of the sternum, and here's the manubrium. The manubrium, manos or manual, is something that is related to hands, so it is the handle of the dagger. So it has a manubrium, a handle, a body, and a tip, a pointed end, and it is a flat bone, easily accessible. So it has red bone marrow inside it, and so you can do a bone marrow biopsy by penetrating it. Now, if you feel here between the 2 clavicles, you feel your manubrium, there is a depression, as a notch, which is called the jugular notch. If you press posteriorly, it is unpleasant feeling because it is the trachea. It is your trachea. You can feel the trachea here. Now, if you go down a little bit, 5 centimeters below, if you go down 5 centimeters below, you will feel this ridge here in the midline. It is called the manubriosternal joint, or the sternal angle. It is an angle in the sense, if you look at it from in profile. In profile, there's a small angle between the manubrium and the body of the sternum. And you can feel it as a ridge in the midline under the skin. Why I am saying this? Because this is very important from the clinical point of view. Usually you can feel the sternal angle, or the manubriosternal joint. If you go lateral to it, it is the second costal cartilage and the second intercostal space, third intercostal space, fourth, and so on. Because sometimes, or in many times, when you examine a patient, let's say, and you need to put a stethoscope, this stethoscope should be put in certain areas on the chest. So if you are required to put the stethoscope in the 4th or 5th intercostal space, then you have to count the ribs and intercostal spaces. And this is the surface anatomical landmark that is usually used to count the ribs and intercostal spaces. Same thing if you want to put the ECG leads on the thorax, then there are certain places to put them, either in the 2nd or the 3rd or the 4th or the 5th intercostal space. So you will start doing that by counting the ribs and intercostal spaces.